In this video, we will discuss the office intervention for moderate to high alcohol use. This approach can also be used for patients with marijuana, cocaine, or opioid abuse. The SBIRT process begins with screening using one of the approved screening tools. The self-report version of the audit is one of the longer screening tools, but has the advantage of providing direct feedback to patients based on their score. The first three questions: how often do you have a drink containing alcohol? How many drinks do you have on a typical day when you are drinking? How often do you have 5 or more drinks on one occasion? Are the ones most likely to determine the level of alcohol use for the vast majority of patients and help differentiate between low and medium risk. For individuals with 8 to 15 points on the audit, the interpretation is, you may drink too much on occasion. This may put you or others at risk. Try to cut down on alcohol or stop drinking completely. These individuals are at risk for injury, interpersonal problems, and medical consequences, and a brief intervention is recommended. One approach to a brief intervention uses the acronym FLOW. Provide feedback from the audit screening tool, ask patients for their views about their own drinking and listen to encourage their thinking and decision-making process, provide medical advice, and negotiate a decision about options the patient can pursue, including establishing a goal and developing an action plan. This is intended to be a 5-minute intervention and is not billable. For patients who score in the high-risk category, the brief 5-minute intervention ends with a negotiated follow-up visit for motivational interviewing. This 15 to 30-minute motivational interview is billable. High-risk patients generally don't need to be referred as you would a patient scoring 20 or more on the audit when addiction is likely. The Health Education Alliance of Maine, in collaboration with Massachusetts General Hospital, developed an online course to support motivational interviewing in primary care offices. This course can be accessed at the URL indicated on the screen. A quick overview is presented here.
Welcome to this enduring material on motivational interviewing. For your convenience, this presentation's been split into 2 activities, each worth 0.5 AMA PRA Category 1 credits for physicians. Credits are also available for psychologists, nurses, and social workers. The first activity, which is entitled Introduction to Motivational Interviewing, is an overview of the motivational interviewing techniques and their implementation. Healthcare workers will find this activity beneficial for a brief overview of motivational interviewing, especially if you don't know basic skills and techniques. The second activity, tobacco cessation and medical adherence, consists of clinical role plays demonstrating the motivational interviewing techniques applied in practice. It has both traditional interviewing techniques and the new motivational interviewing techniques, so you can contrast between the two. This activity is best used to help build or develop knowledge on motivational interviewing. Participants can claim credits for the activities individually for 0.5 AMA PRA Category 1 credits, or together for a total of 1 AMA PRA Category 1 credit.
As mentioned, the 2 patients featured in the motivational interviewing course do not have a substance abuse problem. However, the motivational interviewing approach is generalizable and of value in the primary care office when supporting patients who want to change health behaviors. The National Institute on Alcohol Abuse and Alcoholism also offers online training at the URL shown. The training videos here specifically address alcohol use disorder, which is analogous to the approach for other substance use disorders. An important first step in the motivational interviewing process is to assess the patient's readiness to change. Recognizing where the patient falls on this continuum suggests the approach the practitioner should take in the motivational interviewing session. In the pre-contemplation phase, the patient has not recognized that he or she has a problem and has not thought about changing. The practitioner's role is to raise doubt in the patient's mind. In the contemplation stage, the patient is ambivalent. He or she is not yet ready to change, but recognizes that there may be a reason to change. The practitioner's role is to reinforce this ambivalence and to further develop the discrepancy between what is desirable and what is undesirable about the behavior in the patient's mind. Encouraging the patient to discuss what is bad and good about the behavior supports his or her progression to the next stage of readiness for change. The extent to which the provider will engage with the patient in motivational interviewing will vary. Patients for whom addiction is likely, a score of 20 or more on the audit, will need referral for substance abuse treatment. Substance abuse resources are listed at the end of this online course. Check your understanding by returning to the Moodle and answering the questions.